Welcome to Impact, the Conversation, a podcast of the University of Minnesota's Institute on Community Integration that brings you strategies and stories advancing the inclusion of people with disabilities. Our guests are the authors of Impact, our long-running magazine that bridges the research to practice gap with professional and personal reflections on what matters most in disability equity today. I'm your host, Janet Stewart. Today we're talking with Elsbeth Slater, Professor Emeritus in the School of Social Work at Salem State University in Massachusetts. Dr. Slater's body of work includes extensive disability services research related to addictions. Her pre-doctoral training was supported in part by the National Institute on Alcoholism and Alcohol Abuse. Earlier in her career, she practiced as a forensic social worker in a number of court settings. She brings an equity lens to addiction work and advocates often for acknowledging the dignity of risk in this work. Her article for the new issue of Impact lays out a clinical intervention she conducted that was designed to build confidence and skills for people with intellectual or other developmental disabilities to decline alcohol and other drugs. Dr. Slater, welcome. It's great to be with you today to talk about this work.
Thank you. I'm honored to be here.
Yeah. So can we start with this intervention you did? When was it and what did we learn from it?
Sure. Well, I want to start by saying that this work was led by Dr. Mark Copersino, who's at Harvard and McLean Hospital. We were both interested in a study that was done a number of years ago by McGillicuddy and Blaine that looked at something called refusal skills development. And it was targeted to the community with intellectual and developmental disabilities, and basically used role-playing and sort of mentoring, modeling to help people engage in really self-determination in situations where there is dignity of risk around the use of alcohol and drugs. And so we were both interested in this study, and Mark had already done some work in this area. He's a clinician that specializes in addiction treatment. I had always done clinical case management with this population in both forensic settings, meaning child protection settings, parents involved with that system, and also in adult criminal defense, people coming in due to their involvement. So we had this shared interest, and Mark had access to the clinical population. He has led this work. Basically, building on the McGillicuddy and Blaine study and what exists in the literature, a 10-session treatment program was developed, 45-minute sessions, with the goal of looking at people's capacity to engage in a redirect if they wish to do so around alcohol or drug use, pre-test and post-test, looking at a couple of different variables. And we found that this was effective at helping people to engage in refusal of use of alcohol or drugs. And there are various different types of strategies that we worked on. They were strategies that we developed based on work that Mark found from the James Stansfield Company, which creates curricula for adolescents around alcohol and drug use prevention. So using that material, which was targeted to that particular developmental stage, seemed appropriate. So, for example, Mark worked with folks around role-playing a situation where someone is, say, offered a drink, maybe they don't want to drink, so they are modeling or they're working towards saying no and getting out of the situation. That's one scenario. So it's sort of learning to engage in a particular rote interaction that one can come back to and pull out of their tool chest. Another one might be something like, no, I'd rather not have a drink. I'd rather go to the movies. Would you like to go with me? And then go if the person doesn't want to go on. So there were various strategies that people were offered and practiced during the course of the 10 sessions. And practice, the goal was to practice to automaticity.
Now, you've done a lot of work in the area of dignity of risk, and I think that is so crucial in this discussion because we're talking about adults who can make choices themselves for substances that they may want to partake in. And it just has seemed really important to you in your work to bring in guardrails around this so that we're not hearkening back to the Nancy Reagan era of just say no. How did you build in some nuance to this to make sure that not only in your study people were given responses that really reflect what they wanted, but how do we, as we learn from that study and incorporate the people that with disabilities that we work with, how do we bring that element to the work?
Yeah, I think that's the $1,000,000 question, and I'm really excited that you're asking that question because I've been waiting for 20 years for people to start really wrestling with that particular question. So let me contextualize the question just a little bit more. Um, Part of why the dignity of risk is so important is that the traditional approaches to treating someone for an addiction problem, should it develop, right? Um, is that the standard methods that we have in the addiction treatment sector, which are generally cognitive behavioral therapy, um, there's challenges there in terms of people with intellectual disabilities and developmental disabilities around acquiescence bias, things like that. So there's this worry that I've always had watching folks as a clinical case manager going through assessment and treatment, that there's acquiescence going on that harms the clinician, things like that. So I'm coming at it a step in because I think that's an important piece. There's if we back up and we say, should people have access to alcohol and drugs? I think any community member should with supports, and that's true for everybody, regardless of IDD status, right? But the problem becomes if you do offer someone the dignity of risk to go and have a beer at the bar after work or a glass of wine with dinner or use a CBD gummy, we're seeing a lot of this in the field. Those are normative behaviors. And yet, when there is potentially increased um, potential for negative consequences for this population, the dignity of risk gets really sticky. And then when you add to that the treatment piece, you've got a problem because you don't necessarily know what works with this population very well. And that's where the field has been stuck for a great deal of time. So when I heard about Mark's work and we began to collaborate on in a variety of different ways, this was a conversation that we had a lot. I said, Mark, you're talking about using cognitive behavioral therapy modified for folks based on a different developmental stage, which is great. He focuses a lot on the here and now as opposed to using abstract concepts. That's great. You're talking about motivational interviewing, um, where we engage people, help them focus, help them evoke their goals, and help them plan towards the goals. But to what extent is all of that potentially trampling on dignity of risk, given that acquiescence bias? you know, if we think about just a standard motivational interviewing question that a clinician or a case manager might ask, because this is a tool that doesn't necessarily just need to be used by clinicians, we might say something like, what might be some good things about making this change? That's a nice open ended question, right? And so when working with this population, we don't want to be leading in this way. So eliciting that individual view is super important. So yeah, so there's so many facets to thinking about dignity of risk and how it interacts with the fact that we've had a dearth of information about what to do with this population, but I don't think that should stop us from supporting our people to have normative community experiences. And I know that's controversial in many settings, and I've been a consultant in settings where I've said that, and that hasn't necessarily gone over well. If you think about shared living facilities and organizations that run those, group home shared living facilities, uh, they're thinking about risk management, right? And rightly so. And how do you balance that dignity of risk, which we say we're so committed to, with the fact that our institutions have this risk management as well? So that's group homes
Well,
or
and
shared living
really,
situations, but also same issue for clinicians.
and isn't it really too families as well? Because they have
Oh
just
yes,
as much
even
invested
more,
in not,
even more.
having their family member harmed. So,
Right,
um,
and people have tried to
exactly.
block folks, even with normative behavior. I was just consulting on a case where, an individual who had a parent with limited, guardianship status around health wanted to block that person from using, marijuana gummies, to fall asleep at night, in conjunction with a clinician. And so this is the medical marijuana thing is popping up all over the place, and I'm working on a project about that. But this is a huge issue with families. And I think that's any family, regardless of whether someone has IDD or not, there's this want to protect, there's this need to protect, and there's this impulse to protect. And of course, we know with folks with IDD, we've had decades of knowing that we have to do better in not necessarily completely protecting people from learning in normative community spaces.
And you mentioned the gummies and, with marijuana legalization going on across the country. Do you think that this is really going to be a big spike in issues related to addiction with this?
I
You know,
don't know if
they
it's gonna be a spike in addiction, and this is based on anecdotal evidence, but let me tell you a little bit about what I've been involved with. So, I do some consulting with the START group at the University of New Hampshire, and they provide services to clinicians all around the country. They have monthly meetings with IDD clinicians around behavioral health concerns. And so I've been in a couple of times to meet with them and brainstorm with them and provide them with information about the evidence base. And we are just hearing marijuana, marijuana, marijuana gummies, CBD constantly. And so we did an anecdotal, non-population based survey of the people that participate. And well, they Start did it, not me. And they said, what are the issues? How much are you seeing this? And they're seeing a significant spike in use of these legal materials, which I think we're seeing around the country. But it's harder to say with respect to addiction because we're not necessarily measuring that scientifically, and of course, it's anecdotal. So we really need to do some more work in this area. This is also exacerbated by the problem of not having screening and assessment tools that are validated for folks with IDD. We know that that population has traditionally been excluded from those kinds of studies because they are seen as biasing the sample, but that leads to a backdoor problem of not having the kinds of tools we need desperately to assess what's going on with this population. Side note. So I couldn't say that there's been a spike in addiction around marijuana. I wouldn't be surprised if we're heading in that direction. But I think we need to help the families. We need to help the individuals. We need to help the clinicians. We need to help the staff to remember that if something is legal, people with IDD have every right to use it. But we need that circle of supports to guide from the side, and help people to make decisions and deal with consequences and things like that.
And you mentioned in your article that there seems to be now a surge of interest in talking about this as a field. Do you think the addition of marijuana is driving that, or I think you pointed to some other potential reasons for why there does seem to be a surge of interest in this now? What do you think?
That's an interesting connection you make about marijuana. I mean, I suppose the embrace of legal marijuana is changing the narrative in so many ways for all segments of the population, that perhaps that is a factor. I've really wrestled with why this is happening. Again, I've waited 20 years for people to pay more attention to this. I mean, that's a whole other story. Um, I do think that we're getting better with community inclusion. We're wrestling with the harder issues more. Maybe all these decades of working towards that, um, maybe it's coming to fruition in looking at the harder issues. I call it the sex and drugs and rock and roll issues, of community inclusion, as opposed to where do I live, what do I wear, whose party am I going to, where am I going to work. Um, so maybe we're getting to that good place in thinking about community inclusion. I also think from a research perspective, that perhaps we're paying a little bit more attention to external validity or generalizability in addiction treatment research. And we see that primarily in, I think, the fantastic expansion of research around mental health treatment for folks with intellectual and developmental disabilities. I mean, I've talked to a number of, I mean, there's NAD, there's wonderful work being done out there. So I think there's a critical mass of work around psychotherapy, various aspects of psych or modalities in psychotherapy, for this population. So maybe now we're starting to sort of trend over towards addiction treatment as well. Um, I will just add that I'd really like to see more participation of individuals with intellectual disabilities, in that research in terms of amenability to the interventions, applicability, et cetera. But that's sort of a side note, just to get a little bit of empowerment oriented work in there.
Yeah, and what do you think about some programs have successfully used people with IDD in their in their investigations in their programs, but oftentimes to get the sample size, they'll take
I know,
anyone with IDD
I
without
know.
any experience in addiction. Is that useful at all?
It's something. I mean, it's definitely not ideal, but I mean, we've been doing this incrementally for decades, right? So I think a little is better than not. I'm sure some people would disagree with me on that.
Well,
I mean,
yeah,
to
and but getting to your point though about everything taking so long, and it is pretty egregious when you look at, how old is the ADA, and sort of uh, the equity in that, it just from a healthcare standpoint of getting treatment. But we heard in putting together this issue that a lot of families encounter treatment specialists who sort of throw up their hands even today and
yes,
say they aren't equipped
yeah.
to treat people with IDD. Is that just another convenient excuse for dumping patients? That there's such a crisis in getting mental health treatment and other kinds of treatments. Um, i- i- is there something to that? And is it really less difficult than what they sort of make it out to be, or do they have a point and we just need more training? I don't know. Where do you come down on that?
Well, for 30 years, I've been seeing the same story. Sitting with clients, trying to get them into treatment. We don't work with people like that here. We don't want to turn off our normal clients by having someone with an intellectual disability in this session. We don't
There
know
we
what to do with
go.
them. It doesn't work. They drop out. I've been hearing this for 30 years. I still hear it when I get calls from people in consultations to assist them in what's going on. Um, I mostly get those calls from the disability service sector. Rarely do I get calls from the addiction treatment sector saying what to do, but those calls are starting to increase, which is wonderful. So is that a cop out? Yes, that's a cop out. That's about ableism, but it's also about the lack of the evidence base. However, now we're starting to move beyond these scads of articles we have that document the problem in the population, towards actually some indication of what to do. So I do think training is a big piece of it. Um, Training is absolutely necessary. And we have information to share in those trainings. And I've been doing those and getting calls all the time to do it. I can't keep up with it. But if we don't have people look at their ableism around who should be in treatment, around who should be allowed to have the opportunity to take a gummy, have a drink, or have had that opportunity, it's not going to work. We need anti-ableism, anti-saneism work just as much as we need people to get up to speed on what we've been finding in the evidence base. We're just coming out with a scoping review that looks at all of the evidence base, from screening to assessment to prevention to treatment of addiction in folks with IDD. And our goal was to really get that out there, both to the disability side of the equation, so they can cross-train the addiction side, and to get it out to the addiction side, so they can see what's there. So I hope that answers the question.
Yeah, and what is that work? Is that something that's out and available now?
It's under review right now, but
Great.
the last review was just for grammatical stuff, so I'm hopeful that it will be published soon.
Wonderful. That's great news. So, at the end of your article in Impact, you talked about sort of posing this question of, you know, a lot of what we've done so far is sort of adapting curricula for the wider population to people with intellectual disability, for example. Do you have a suspicion that people with IDD just fundamentally need a different approach, not just translating it? I don't know. What do you think?
I think we should ask them. And that gets to your issue of sample size. We had such a hard time recruiting for Mark's clinical work. We ended up with 30 folks, but it took years of getting people in the room. So part of the problem in terms of bringing people together is locating them, and locating folks that are willing to speak openly in that way, and then managing acquiescence bias. I think you'd have to take a triangulated approach. You want individuals in the room to talk about their experience, what they think works, what doesn't, what something else might look like. Is it possible to vision? I would like to think so. I think you get collaterals in the room. One of the things we found in our scoping review is that a number of studies are starting to use a support person in sessions, and this seems to assist with positive outcomes after the intervention. And so I'd also want to hear from the collaterals, the family members, the girlfriends and boyfriends and partners, the staff people, things like that. I think we need all hands on deck. And I love your idea. I think it's a very empowering idea.
Great. So we're about at time, but is there anything I haven't asked that you think is really important to bring out in that intersection of addiction and disability?
I think you've asked the key questions. I just want to highlight again that our addiction treatment service provider community needs to look at the ableism piece. As you pointed out, the Americans with Disabilities Act, how many decades have we had it? I see regular violations of access to addiction treatment for folks with intellectual and developmental disabilities based on the consultations that I do. I hear it all the time. And so, honestly, to some extent, I think maybe if someone starts a lawsuit, that'll help things. We've seen how that's gone before, and that's unfortunate to say. But I hope that the folks that listen to this who are on the ground in the IDD sector make friends with folks in the addiction sector, create that personal connection, do informal cross training. Here's how we get comfortable working with a person with IDD. So often the addiction treatment providers say, I don't know how to talk to someone like this. They're uncomfortable. That's ableism. That's also just, not knowing the population. Get to know the population, learn how to do better for our people. So those are some other thoughts.
Dr. Slater, it's been so great talking with you about this. I really appreciate both you writing the article for Impact and sharing a little bit more detail here with us today. Thank you so much.
You're welcome. Thank you for the work you're doing.
Thanks for joining the conversation. If you'd like to reproduce all or part of this podcast, please email icipub@umn.edu.
Our show is co-produced at the University of Minnesota's Institute on Community Integration by Impact Managing Editor Janet Stewart and ICI Media Producer Pete McCauley. Skylar Mihailov is our editor. Graphic designers are Connie Burkhart and Sarah Kurtner. For more information on the Institute and all of our products and projects, please visit ici.umn.edu.